Good morning, everybody, and sorry for that slight delay, but hopefully we can catch up very quickly with Yatna now. And so today I'm really pleased that we've got Yatna back. So if you remember, well, Yatna, you can introduce yourself again to everyone and explain who you are and what you do and why you're back again.
Hello everyone. If you came to joined to my last webinar back in July, we were just talking generally about feet. I'm a podiatrist. I work for the NHS and I also have my own private practice in Finchley, and I work in London Bridge in another private clinic also. Very passionate about feet, obviously, being a podiatrist. But also I'm very passionate in the people that have the feet, because we don't just treat the feet, we're treating a person. So it's a holistic view of a person who has a foot problem. So today I've been asked to talk, pardon me, to talk about diabetes in relation to the feet, which is a bit more of a serious topic than my last webinar, because diabetes is on the increase in England. Health, cost of living, cost of buying food, people's education into nutrition and what you should be eating and shouldn't be eating when you've got diabetes. A lot of this is leading to obesity, which can then increase your chances of type 2 diabetes.
So I think it's really interesting because we do hear some really shocking headline news about diabetes and feet. And I presume that a lot is sort of scare tactics, but at the same time, it's really important because obviously the seriousness is people lose their feet, and it is important that this is actually a reality if you don't look after or manage your diabetes and look after your feet at the same time.
Absolutely, it is a bit of a scare tactic, but sometimes it takes scaring people to get them to kind of be aware of what's going on with them. So obviously I'm going to keep referring to feet, but yes, the most serious scenario with diabetes is actually an amputation, is losing a part of your foot. We either be half your little toe, your whole big toe, from the forefoot and below, ankle and below, or below the knee, above the knee. And that's the worst case scenario. And us as podiatrists are trying to educate as soon as someone gets diagnosed with pre-diabetes or has diabetes, so that they can make the right changes at the right time, right in the beginning, so they don't go on to losing their feet.
And why is it that feet are so affected by diabetes?
Okay, so the diabetes has a huge impact on the body in so many different ways. So and I've got quite a lot to talk on this topic, so we may not hear you, I'm afraid. It might just be me talking. So first of all, how does diabetes affect the feet? The most common and obvious one is neuropathy. So what is neuropathy? Basically nerves dying. The ability for the nerves to make you feel your feet, make you feel pain, reduces, or you lose that. Okay, so one way that you can start to realize is happening is that you start to get loss of sensation in the feet, tingling, burning, and pain. Predominantly the burning pain happens during the night because we're lying flat, so the blood flow to the nerves is not there, so therefore the feet feel like they're burning at night. Okay, also it feels like you're walking on cotton wool. So if you're not controlling your diabetes, your reduction in sensation happens quicker, and that feeling of walking on cotton wool increases much more quickly. You also can't feel things inside your shoes, so there could be a piece of glass or a stone inside your shoe, and you wouldn't be able to feel it. And because you can't feel it, that can pierce the skin, and again, you wouldn't feel if you have a cut or a blister, or, you know, something, you don't have that alarm system in your foot anymore alerting you something's wrong. Okay. This actually happens in 50% of people with diabetes if you don't control it.
What, they lose all sensation?
Pardon?
They lose sensation in their feet?
Yes, it reduces. And the complications of diabetes start to set in more quickly when you don't control your diabetes for long periods.
And if you're controlling your diabetes, then do your feet improve, or do they stay at the sort of same level? Can you improve your feet if you improve your diabetes?
So if we stay on the neuropathy side, so the loss of sensation, no. Scientists are still trying to regenerate nerves, and you can't get back the nerves that you lose. So this is why changing your lifestyle, your education on diabetes right at the beginning can stop the worst case scenarios of neuropathy happening in your feet. Because once you lose those nerves, that's it. So no matter changing your nutrition or anything is going to bring those nerves back. So it is more a case of managing a foot that you potentially can't really feel the true feeling of.
Gosh, I didn't realise.
So no, you can't reverse neuropathy.
Does that, I'm sure that I'm leaping ahead of you know, where we're at, but I didn't sort of realise quite, you know, that, because, you know, I think if we get things under control, we can gain back what we have lost. Clearly, that's not the case. And then I suppose when you then lose sensation in your feet, apart from the things that the obvious things of treading on something and thereafter, but does that make it very difficult for your balance and walking?
Absolutely, because if you lose a sensation, your proprioception goes, so your balance reduces. So then, yes, you are more prone to falling over. You are more prone to hitting things. You know, walking into the bedpost, I'd feel that. I'd say a few little swear words. A diabetic person with diabetes who has lost their sensation won't feel that. A little story, not a scare tactic, but obviously stories are good. I had this gentleman in his 40s, uncontrolled diabetes, poor circulation, a topic I am going to go into. It's next on my list to talk about. And he was just in bed, and he must have knocked his toes on the bedpost at the end, woke up, and he started to see little black bits on his foot. Thought nothing of it. Within 2 or 3 days, he presented in my clinic, and he lost all of his toes, just like that. Yeah. So that's why it's really important to be checking inside your shoes, checking the bottom of your feet. Like, you don't even have to look, just get your hand and rub it on the bottom of your foot, because your hand will feel if you've got something stuck in there. And it's those small things. It's putting a mirror on the floor and putting your feet in the mirror and having a look that way. I know this is mainly to men, because like it's mainly my male patients that do this. Women tend to change their socks every day, or their tights, but changing your socks every day, you know, some people out there are wearing the same socks every day. So hygiene, washing in between your toes, drying in between your toes, getting someone who you live with to check between your toes. I'm finding a lot of family don't want to help out. Oh, feet, I don't want to touch them. But I just think it's such a small task. And with COVID and everyone overbuying gloves and masks, you've all got gloves at home. Put some gloves on. Have a check between the toes for a family member. You know, it's those small things that can save someone's foot, because I don't think we realise how much we use our feet till they're gone. I always say I would rather lose my arm than lose my leg, because independence is a big thing when you lose your feet. You can't walk anywhere. If you lose one foot, you're in a wheelchair, a prosthetic leg. But a prosthetic leg isn't always viable for someone with diabetes, because having to put those screws in and the fitting of a prosthetic leg, if your diabetes is not well controlled, your body cannot heal the prosthetic part in the top part. So you can't have a prosthetic leg. you will start to depend more and more on family. So again, going back, if we can get the education and people on board with their diabetes, investing in their health right from the beginning, you can stop these problems. You can stop them really, really quickly and stop them getting worse.
But I suppose it is. So one of the first things is if you're, I suppose, pre-diabetic, do any of the symptoms show in your feet, or is it only when you've really been?
So your feet won't necessarily tell you've got diabetes. It's more of the kind of the symptoms that come with diabetes that are going to tell you've got diabetes. So just so that we've got this in this webinar, the main symptoms of diabetes, if you're pre-diabetic or don't even know that you're diabetic, are you start to go to the toilet quite a lot, and especially at night. But compared to type 1, where the symptoms are very obvious and happen very quickly, type 2, it slowly comes. And because it's predominantly in 45 and above, so we're talking middle age and above, you might think, oh, it's just me, I need to go to the toilet a lot more, I've been drinking a lot more. And it takes a while for you to go, actually, I'm not drinking a lot more, I'm going a lot more frequently, something's wrong here. Okay, I go to the toilet quite a lot because I drink tons and tons of water, but I don't think diabetes because I'm only in my 30s. But if I was in my late 40s, I would start to question that, especially having people with diabetes in my family.
I think also, just very quickly, one thinks, oh, something's changing in your body, you think it's just age, and you shouldn't.
Yeah, a lot of people put it down to age, and it's like, actually no, I treat 90-year-olds who have better feet than 40-year-olds. That's not age. That's not age. So tying in with the going to the toilet a lot, you actually do become really thirsty. So again, you start to become thirsty, so you go to the toilet, you drink more, so you go to the toilet more. So you don't think diabetes, but actually, these could be the first symptoms that you start thinking, oh, I might have diabetes. Other things are that you become more tired than usual because your body is using more energy, losing weight without trying. I had a patient in clinic the other day, actually, who said to me, I just keep losing weight. I'm not doing anything. I said, oh, you're not going out for walks a bit more? No. I said, why don't you pop to your GP and have a blood test, see if you've got diabetes? Oh, it can't be diabetes. I said, why not? We totally dismiss it because we're so used to seeing diabetic people with diabetes looking fat. But you don't have to look fat. I have tons of patients that are quite slender who have type 2 diabetes. So it's not a visual thing. Don't assume just because you're on the larger side that, oh, it's got to be you have it, or you're on the thinner side that you haven't got diabetes, because it affects anyone. But there are main physical features of diabetes that we do look for. We do look for predominantly more overweight people, carrying more weight around our midriff here. Other symptoms of having type of diabetes, and this is connected with your feet, and this generally would happen when you've got diabetes, if you know it. But again, for us, if I was treating the patient, it's cuts and wounds that take longer to heal, ulcers. So the definition of an ulcer is a cut or graze that takes longer than 4 weeks to heal. Because for you and I, you don't have diabetes, do you?
No.
Okay, so for you and I could cut my hand today. By Friday, it should have kind of stuck together and a scab should have started forming. Someone with diabetes, that wound's still open. It's still weeping. And if you've got diabetes and you know about these things, the first thing you would be doing is calling a podiatrist. Your local, if you're part of under the NHS podiatry, you should be calling your local foot team, which is your podiatry. Or if you're not, come and see me, a private podiatrist. We can do a diabetic foot check, have a look, and we'd give you that advice to say, right, you need to go into your GP and get a referral to your podiatry team. Your local NHS podiatry team should see you within 48 hours, 24 to 48 hours, if you're diabetic with a wound that isn't healing. They should do.
Funny enough, I went I was on holiday and I was bare feet and everything, and trod on something, and I came back, and after 4 weeks it still hadn't healed. So someone said to me, oh, I think you should go to A&E with that, because it's just really painful. I didn't think anything of it, and they looked at it, and then they checked my glucose levels, and I had no idea.
Yeah.
Right. And then and then later on I understood they were checking for diabetes, and I was like, I have to say slightly horrified, because I was thinking, right, no, exactly like the previous person you spoke about. I was thinking, no, I absolutely don't have diabetes. I don't have diabetes. And then it's built up. No, maybe it's because I had, because I had going on the beach and all of those things.
Probably because it was wet and it kept opening up. You weren't giving it time to heal. Because with people who've got wounds, we would ask them to keep their foot as dry as possible. They shouldn't be showering, or they should be showering and keeping that foot dry in order for it to heal. But mainly because with diabetes, your rate of healing reduces, but your rate of infection increases. So you take longer to heal, but because that skin is open, it's like a door, but your front door being left open, burglars will just come in. So it's like infection can just get in easily and manifest and multiply much, much more quickly, which is going to bring me on to my next topic of blood supply. So diabetes does actually reduce, it lowers the amount of blood getting to the feet. So if you're taking a long time to heal and you haven't got enough blood getting there, so the nutrients not getting down to your foot where the wound is, or infection will quickly multiply because the blood's not getting there to take it away, and the natural immune system is not working to fight that bacteria. So the blood's not getting there, the infection's going up, it starts to spread. And if you can't feel that and you're not checking your foot every day, that will spread very, very quickly. And it only takes it till feeling unwell, systemic signs of infection, when the infection has actually got into the bloodstream and affecting your body, fever, cold sweats, feeling unwell, flu-like symptoms. That's when you then go, oh, I think I feel really ill, I'm going to go to my doctor or A&E. And actually, and this is why we did a transformation project and worked with Northwick Park, Hillingdon Hospital, some central London hospitals, in educating A&E staff to do a diabetic foot check, or a foot check on everyone that comes into A&E, especially someone with diabetes, because we found that a lot of patients were turning up at A&E and their shoes weren't being taken off, or their socks, they were just in there. Bloods get taken, obs get taken, infection markers are high. One question, have you checked their feet? No, they hadn't. They'd have taken their shoes and socks off, they'd have seen there was a great big gaping hole in the foot. That's what they need to treat. Buy the antibiotics, get on top of the infection, you've saved a life, you've saved a leg.
And have they still carried on doing that, do you think?
Yes.
It sounds
the
like
education, the feedback from that education program was so good. We now have, through the rotation of the hospitals that we work in, the junior doctors coming through are saying, oh, I remember your talk that you did to all the doctors and that, and has stuck in people's minds, because it takes 2 seconds. Take the socks off, check the feet. That's all you need to do. Refer to podiatry or refer to the diabetes specialist. That's all you've got to do. It takes 30 seconds. 30 seconds to save a leg, to save a life.
Gosh. And
it is simple.
Yeah, those simple ones. So when people come with you, I think, because we spoke earlier, there's quite a different number of things that they present with to show that there are issues that do need to be taken seriously and sorted.
So are we talking about the changes to the foot in relation to diabetes? Yeah.
Yeah, so we're talking about the toes and things like that.
Yeah. So some of the more serious things. So if we step away from poor circulation and losing your foot. So because most people with diabetes can get neuropathy, so loss of sensation in their feet. What happens is the nerve innervation to the muscles reduces. So we can get a foot shape which is like a high arch foot. Now, some of us are born with feet this shape, which is absolutely normal and fine. We learn to adapt and learn to live with these kinds of feet, these types of feet, foot shapes. But with diabetes, because the nerves aren't telling the muscles what to do, we go from having a foot kind of, let's just say like this, to the toes starting to, use this hand, bending like this. So you can see from my hand, we've created pressure points, areas that can rub in our shoes and on the ground more. So we've got the tops of the toes. So the knuckles, let's call it the knuckles of the toes, they can start to rub a lot more on the tops of your shoes. Because we've got a reduction in blood supply, reduction in feeling, and a reduction in healing. What happens is we cause blisters. Now, everyone can get a blister. But when you have diabetes, these blisters you don't want to be getting. The blisters rub. The blisters will then break, which we don't want to have. And because we can't heal properly or quickly, they cause wounds. Or over time, if the toes start to change shape and we haven't changed our footwear because we're not under a foot team or seeing a podiatrist for education, or we haven't educated ourselves on good footwear, we cause callus, hard skin. So the hard skin then builds up. The hard skin rubs on the shoe, but the fresh skin, normal skin, rubs with the hard skin, and this causes like a blister in between. So, and causes the skin to break down. And because if we've got poor diet in diabetes, the cells aren't getting enough protein for protein synthesis to rebuild cells. So they break down much more quickly. The skin is more fragile. So they're not as tough anymore. So, you and I would get a blister, and the skin would redissolve that fluid within a couple of days, cause build a little scab. The scab will fall off because underneath the fresh skin's healed up. But in diabetes, that doesn't happen because the toes stay like that, and we don't feel what's happening. So we don't get that connection. Oh, something's rubbing. We wait until we've got hard skin, or we wait until it's broken down. Same. Go on.
I was just going to say, so your toes, once again, that's another thing. Presumably, can you do physiotherapy to get your toes to go straight again, or is that it? So then you have to look at your shoes. You have to change your shoes, basically.
Yep. So once your toes start to retract, or should we just say bend or become bent, you need to now then start thinking about deeper footwear. So footwear that will fit and not rub on top. And this can become difficult. But having better footwear, and obviously educating yourself right early on when you get diabetes, if you change your footwear, you can slow down changes, because you're allowing your foot to have that space. Having ill-fitting footwear will actually push your toes to get bad more quickly. So it's the same with bunions. If you wear tight-fitting shoes, you're forcing that joint to move over more quickly than it should. But if you wore better shoes, you can slow down the rate that happens. So with this one, yes, you can slow down or stop foot changes happening more quickly by good footwear and good foot care.
And also, you then don't get into that sort of it doesn't heal, it just sort of repetitive cycle. You're stopping that repetitive cycle going, which is
you're stopping the tension on those joints. So you're stopping the hard skin happening, because once the hard skin starts to build up, that area then needs as protection, because that's why hard skin occurs, because of protection. When the toes start to claw, the bottom part of our foot starts to touch the floor more, because the joints are more exposed, so they're sticking out more. So we then start to create high pressure points on the first, the third, and the fifth joints, and these are the more common areas to be getting ulcers on for people with diabetes. And this is where the callus builds up, and underneath it breaks down, and that's why you go to see a podiatrist. They take all that hard skin down, and that's when they reveal there's an ulcer there. And that's why people normally blame a podiatrist. Oh, a podiatrist caused my wound on my foot. We didn't. We actually found it. It's been there for a while. We just discovered it. And if you are seeing a podiatrist regularly, they will manage that hard skin. They'll manage it with padding to offload those areas, insoles in your shoes to offload those areas. So getting that done more quickly when you start to see those changes in your foot, and you know, you don't have to start getting hard skin to notice. You start to feel, let's just say, it feels like you're walking on pebbles a bit more. That's a good indication that, oh, my foot might be changing. I need to now look into footwear with a bit more cushioning. So the easiest way for me to describe cushioning is a ballet pump versus a trainer. So the sole of the foot, the shoe on a ballet pump is a lot more thinner. Actually, give me 2 seconds. I'm going to get 2 pairs of shoes. I'm now going to show you how wacky my shoe collection is as a podiatrist. So here is a Primark. I'm not paid by Primark to sell their shoes. Here is a Primark shoe. As you can see, this has a really thin bottom. And it's what I would just say completely flat. Can you see? It's so flat. So when you're walking, there's no shock absorption. So on the bottom of our foot, we have there to absorb shock when you're walking on the floor, or pavement, etc. There's no support here at all in this shoe. Nothing for the ankle, nothing for the midfoot. And as you can see from the back, can you see how it just squashes down? That's really bad. And the best thing is, we're coming to winter. Watch people who wear Ugg boots from behind. Awful. So
they're not
trainer, much better for you. You don't have to buy them in these jazzy colors. You can buy them in plain black, and they don't have to be expensive. But can you see the difference here? This is the sole of the shoe compared to this. Can you see all of this protection on your foot? So if something drops on there, it's going to bounce back off. It's not going to go in your shoe. It's also, if you see with the lace, you should be taking your shoes off, undoing them, taking your foot out. Then when you put them back in, you put your foot back in, and you use the laces to tighten it like a vice, so you get that support. So the shoe is actually strapped onto your foot. This is not. The amount of times that you see, like, I don't know, have you ever seen a woman, like, this could just fall off. Your shoe's back there, and your foot's back there. This is going to stay on your foot. But you've also got, like, for your heel, the back of your ankle to support it. So you've got good ankle stabilization. Your ankle is all over the place. Hence why you'll see when you watch people wearing Uggs and these types of shoes, why you can see their ankles are rolling over, because there's nothing there supporting your ankle. Next minute, you've got ankle pain, and it's probably because of your shoes. So many times I get mainly women coming to my clinic and saying, I've got ankle pain. Straight away I go, okay, so talk to me about the shoes that you wear. Well, I wear these slip-ons straight away. I can say, there's nothing I can really do for you except tell you to change your shoes. I would also really say avoid slip-on shoes, because there's no support there for the midfoot or the ankle. This with slip-on shoes, so we're talking flip-flops, sliders, awful shoes, awful shoes, socks and sliders, not cool. Any type of slip-on shoe. So this is a slip-on shoe. What happens is, because you've got nothing supporting the midfoot, so nothing fastened onto your foot, what happens is your toes claw, they grip to keep the shoe on. So the best way to is watch someone wearing flip-flops or sliders or sandals that have, the slip-on sandals. You will see. So over time, your toes will start to just go like this, because you're gripping to keep the shoes on.
So that's why then you start doing the bit here that you mentioned on your knuckles, and it's that vicious circle, especially, and then as you said, for diabetes. So all of that can happen to anyone, but for people with diabetes, the biggest problem is it doesn't heal.
Yeah.
That's the real message.
It creates hard skin, which rubs on the fresh skin, causes a wound, and takes a lot longer to heal. And because your feet are the furthest, or your toes are the furthest away from your heart, the blood flow gets less and less and less. So think of it like motorways, A roads and side roads. You've got your big arteries, which are motorways, gushing blood down. And as you get further down, you get A roads, which are, a bit smaller. Then you get your capillaries, which are tiny side roads. If you have a blockage in a big artery, so this is what we call calcification. So if you're not eating a healthy diet over time, you will build up a layer of fat inside your arteries. And so as the hole gets smaller, the blood trying to get through gets harder. So this is one thing I was going to talk about when I was going to talk about circulation. One thing that patients with poor circulation can get is something called intermittent claudication. And if you're you've got diabetes with poor circulation, now this can be tested by your podiatrist using the Doppler, and they'll listen to the two main arteries that go to your foot, the dorsalis pedis and the tibialis posterior. They're the two main arteries that go to your foot. They will check those. If you start to walk, and after, let's just say 300 yards, which isn't a lot, you start to get a cramp feeling in your calf muscle. So it feels like it's squeezing, that you have to stop. And then after stopping for 5 minutes, it feels better and you can then start going. That's not a good sign. That means that your arteries are getting calcified with fat, which means the circulation to your legs is not very good. So if you've got a diabetic foot wound and you haven't got good circulation down there, if you then go on to get an infection, think about how far away your foot is from your heart and your mouth. You start to take oral antibiotics. By the time it gets down to your foot, the concentration isn't very good. Hence why you need to be on long-term antibiotics. We're talking months of antibiotics. So the reason I'm saying all these things is because, it takes a toll on your life. You're at the podiatrist or your podiatry team every week or every 2 weeks having your foot debrided, so the dead tissue removed, checking how deep that wound is it healing, and you can be on, we're not talking 2 weeks of antibiotics. I've got patients that have been on antibiotics for nearly 2 years.
Really?
And with everything with antibiotic resistance in the media now, people getting a cold and saying, I need antibiotics. Why? You don't have an infection. If you don't have an infection, you don't need antibiotics. You need to let your body heal. Because as you get older and you get things like diabetic foot complications and need antibiotics, if you've started taking antibiotics at such a young age for silly things that you don't need it, you build up a resistance. So when you actually need it, things that coamoxiclav, flucloxacillin, amoxicillin aren't working because you've built up a resistance because you've had them for so long. And that's then when we lead into taking more expensive antibiotics. We had a patient on ertapenem. Now, ertapenem will cost the NHS, for someone with a diabetic foot wound, £1,000 a week. And you need that injection every day. You cannot have this at home. You have to come into hospital every day. So if we want to talk about costings on the NHS, for one antibiotic for one person, £1,000 a week.
And the cost on that,
think about that over a year. That's £52,000 if you're on that for a whole year, which you can't. You have to have a blood test every 6 weeks to check your levels, because it can have side effects. But we aim not to have people on ertapenem and things like that, amikacin, things like that, antibiotics which are really expensive for too long.
Totally. So just running through the list, so the changes that you can see are the high arches, which we spoke about earlier, weren't they? The retractable toes, loss of sensation, which is what we've definitely spoken about.
There's one more foot shape I just want to talk about, which is really important. It's called Charcot's deformity. Now, Charcot's happens and the main thing would look like a flat foot, a rocker bottom foot. So the foot, let's just say, was like normal, goes like this. It bends at the bottom. Now, what happens in the Charcot's deformity, it's microfractures of the joints in the midfoot. And that's where you get these tiny, tiny little fractures, and they don't heal. So the foot basically goes like that, which creates a pressure point. It's also due to you would have neuropathy as well, because you wouldn't feel it, but you would also, the main test that we would do as podiatrists is we check the temperature. There's a degree change in temperature from in that midfoot, and it's like a volcano. It can be dormant, and then suddenly you can have a Charcot flare up. And the thing with this is once this deformity happens, you cannot go back. You will have that rocker bottom foot for the rest of your life. And it is very difficult to manage.
And is that because of, if you have diabetes, you're more prone to it?
Yes. The major kind of things that you will get Charcot's is diabetes. It's very, very rare to get it when you haven't got it, but in diabetes, yes.
And so it's similar to flat foot when your arches of...
Yeah, so it's what we call a rocker bottom foot. It's where you had an arch, and then suddenly the arch is gone. So it goes, you got a normal foot, and then suddenly it goes like that, and you get the rocker bottom on the bottom.
Gosh, and does that make walking hard?
Yes. Yeah, because you will get ulcers a lot more.
Okay. All right. And is there anything else that we should look out for? One of the ones I wrote down, which I actually noticed because I went and had a look on the diabetes charity website, which I have to say is absolutely excellent.
Yeah, there's some really good websites out there. Diabetes UK has done so much.
Yeah.
So if you are finding what I'm saying really difficult, or you want more information, go over to Diabetes UK, and they have got a plethora of information on there. And they do study days, they do loads of things. They have events. It's amazing. They've done amazing work.
But the reason I said it is because I wrote it down here when we spoke previously, and I've just noticed it on their website about the loss of hair on your feet.
Yes.
Who would have thought?
Yeah. That's one of the things. So when we do a diabetic foot check, one of the things in our little thing, our checklist is, does the patient have hair on their foot? Can I just say, don't live by everything that I've said. Don't think, oh, I've lost my hair. Oh, my feet are cold. Oh, I've got problems. When I trained to be a podiatrist, the first thing first year, I remember thinking, oh my God, I've got hammer toes, I've got bunion, I've got everything. Please don't think, oh, I've got everything, because I haven't got hair on my feet. I don't have diabetes. But one of the things that we look for is, do they have hair? Because loss of hair or on the foot when you had it can indicate poor circulation, because you're not getting enough nutrients down to the foot, so you do lose the hair. So I think the main one is, we see this on men, and we see like, you can see there small tufts of hair or a few patches of hair, and as you go up the leg, you can just see as it gets hairier. That makes sense. But you can see it on like the calf, the front of the calf, where we can see like loss of hair. But obviously we would look for that. We don't expect you to be like looking at your feet and going, oh, I've lost all the hair on my foot, or I don't have any, oh my God, I've got diabetes. It doesn't work like that. But that's one of the symptoms. One of the symptoms is loss of hair. But
I think that's it. Lots symptoms it's generally a collection of symptoms that are sort of telltale signs. It's not just one off, isn't it?
Yeah, no, it's not.
So I think we've probably gone through the main sort of symptoms of the issues, and then it's more about how to manage these issues. And I know one of the things that you've gone really well into is about good footwear. Yeah.
So I'm going to kind of just briefly talk about some of the things to look out for. So shoes, you want to make sure that they're nice and wide. They're not narrow at the top. So nice and wide. So these are more rounded, but you don't want anything that's really narrow. So we're, you know, like this, okay? Because just think, your foot, your shoe doesn't change shape for your foot does, okay? So the best way to test this is get your cereal box or a piece of paper, draw around your foot, put it in your shoe. If the sides curl up, that means that's what's happening to your foot. It's pushing on your shoes, on your foot, okay? Make sure that they're nice and deep. So they're nice, there's a nice bit of depth here for your feet to sit nicely into, okay? And obviously we always say have some sort of fastening. So laces are really good. One tip or one bit of a fact, our feet when we wake up are really nice and skinny and slender. As we walk around, fluid builds up in our ankles and our legs. Happens to me. I'm in my 30s. I have a sitting down job. My ankles swell. So if your foot's swelling and you're slipping your shoes on and off, you're pushing your fatter foot into a tight shoe. And if you've got neuropathy, you won't feel that. You won't feel the pressure. So you must undo your shoes when you take them off and then do them up so that you're readjusting the fastening. So laces are good. A Velcro strap is good, or a buckle. I would try to avoid slip-on shoes, okay? Now, there's always compromise. You know, we all want to have fun in life. So I'm not saying you can't wear bad shoes. I'm just saying wear the right shoes for the right job. If you're walking to work, wear some trainers. If you're going to a business meeting, fine, wear your bad shoes, but only for the meeting, not all day, okay? Don't walk down the street in flip-flops, okay? So yeah, wide forefoot, so here, and nice and rounded here, not narrow, and a fastening, okay? And something that comes higher up the front of your foot. Anything down here is not supporting up here, okay? So because we're going into winter, I really want to hone this into people with diabetes. If your feet get cold, don't put your feet in hot water. Don't put your feet on the radiator to warm them up. If you've lost the sensation in your feet, you will not feel that the burn in the hot water. You will not feel the burn against the radiator, okay? So this goes for getting in a bath. This is not, and now this is normal education that we give to people with diabetes. If you're running a bath, check with your elbow how hot water is, okay? If it's too hot, put cold water in. Do not step into that water. The amount of people that we see in winter with burns on their foot, basically, or coming in with blisters where they haven't bothered to check the water.
Oh gosh.
And yeah, and that can take how many weeks or months or years to heal, just because you didn't check the temperature of the water. Always do this. Ways to warm your feet up: put more socks on, get a blanket, put more clothes on. Do not use a hot water bottle on your feet. If you're going to use a hot water bottle, you put it in your bed to warm it up and then you take it out. You do not sleep with a hot water bottle on your feet, because you will wake up with burns on your foot.
Oh gosh. Because
you can't feel it, okay? And if you're not checking your feet, how long before you check it, okay? So another thing, don't sleep with your bed next to the radiator either, because I do have a patient that does this nearly every year, or should I say did this, because he actually went on to die, and he was only in his late 40s.
Oh dear.
Yes. And because he didn't take on the education, every Christmas he would be back at the hospital with blisters on his feet, where he sleeps next to the radiator, and he doesn't want to move his bed. He actually died of a heart attack. People don't die of diabetes. People generally die of poor heart conditions, because some of the, once you have diabetes, you are more predisposition to get heart conditions, so high blood pressure, and go on to have heart attacks. Hence why having a more healthy lifestyle getting out every day for 30 minutes of exercise, and it's a brisk walk, not a slow walk, a brisk walk. Get that heart rate up, because that helps to burn fat. And the fat that's around our major organs, our pancreas, which we need, which is not working as well to produce insulin, people with diabetes, we need to reduce that. Okay, and it's good for you mentally and physically. Okay, because you do want a good mind. It's not just about physically. We need to work on our mental health as well. Okay, so get out for a walk, or if you've got a bike at home, a static bike, 30 minutes of brisk cycling. Okay, check your feet after for red spots, any rubbing, especially if you've got neuropathy, because the pressure that you're pushing with your foot, you could be getting hard skin. You could have got a blister from pushing too hard. So keep checking your feet when you're doing these activities that require pressure. One thing I'm going to say as well is, remember, your feet have to take on weight. So if you've got a backpack on your back with 5 kilos on it, that's 5 extra kilos your feet have to carry. If you're carrying 5 kilos of extra body weight, then just think about the extra pressure on your foot. Okay, and the pressure on your ankles. So reducing your weight slowly, so making adaptations to your diet, enjoy what you eat. We're not saying cut out cake and sugar. Everything that goes in your mouth, the cup of tea I'm drinking right now turns to glucose. Glucose is sugar. So bread turns to sugar, rice turns to sugar, vegetables turn to sugar. So it's not just cutting out cakes and crisps and fizzy drinks. It's having a healthy, balanced diet. High protein, some carbs, some fat, because our cells need this. Our bodies need this for energy. If you don't have the energy, you're not going to be able to go for that walk. You're then going to become sluggish and more tired. You will then sit at home. Your weight will start to increase. Your chances of diabetes increases. Your chances of heart conditions increases. Okay, so you can see the knock-on effect. And all we have to do, go for a walk for 30 minutes a day and watch what we're eating every day. Enjoy a French fancy now and again. Enjoy a few cubes of chocolate, 1 or 2 pieces of chocolate every day, but don't have the whole bar. Okay. So it's about moderation. We do need to enjoy life, and as much as we do scare tactics with diabetes, we also have to help you manage a happy life, and I think sometimes talking to people like me or people in my profession, your GP, or going to support groups of diabetes, local, or your GP should, or your local podiatry or area should have local, like Desmond and Daphne clinics, or learning programs that you can go to learn about diabetes, especially if you've just been diagnosed or you've been told you're pre-diabetic. Because I think a lot of people don't realize is that you can't cure diabetes unless you have a transplant and you get a new pancreas. But you can go into remission of diabetes. So if you get told you're pre-diabetic, if you make changes to your lifestyle, so look at your diet, get some more exercise, within 6 months, you can go into remission of diabetes. So you don't have diabetes. You're not diagnosed with diabetes. So you can stop yourself going into what we call full-blown diabetes, where you need medication to manage your diabetes. And just to say, please don't think just because you take 1 tablet of metformin that you're okay. You're not. The fact that you're on medication means you have a problem.
And I think they've proven so much now, haven't they? Like Michael Mosley and people like that, is to show how, if you manage your lifestyle properly and you don't have to go to extremes, you can really get that under control. I think,
absolutely,
the one thing that really worries me most is the fact, and especially as you get older, that falling, the issues that falling have, and also as soon as you're off your feet is not great for so many reasons.
Absolutely. So as soon as you can't use your feet, you become dependent on people, your mental health goes down, and your quality of life decreases. A little statistics: if you have a below the knee amputation, within 5 years you are most likely to either lose the other leg or die.
Oh my gosh, that is quite frightening, isn't it?
So again, going back to what I said, if we can make those small changes right at the beginning when you're diagnosed with diabetes, or even now, okay, if you're controlled, that's fine. So why not manage it a bit better, lose a bit more weight, because you can actually reduce taking metformin or other medications and become diet controlled diabetic and just manage it with your diet. And that's just from education.
So I'm just sort of aware of timing. I've got a couple of questions sent in earlier, which I can go through. I'm not sure we've got any, nobody's put any in at the moment. So if you do have questions, please feel free to quickly put them in now. We're talking about how to manage. We didn't mention about nails, but obviously it's really important to keep your nails short on your feet.
Yep.
We've spoken about ulcers. The other thing was is it the spider veins? Did we mention about those, or is that just my?
Spider veins. You can get. Oh, I've got a few. Varicose veins. No. Spider veins. They're just the little tiny capillaries coming up to the show. You don't want them to pop or anything like that. But it's not one of the main things for diabetes.
There might be a red herring there, possibly.
Yeah.
Right. Okay. So just very quickly then, on to the couple of questions that I do have.
Yep.
If somebody notices that somebody basically has said it was a bit of a long email that I have made shorter, but basically they've got some problems. Who should I go and see? Is it my GP, or should I see my podiatrist, or should I see a podiatrist? I imagine from what they've said, they haven't seen a podiatrist before, and they have got diabetes.
Okay. If you've just got diabetes, you can go and see your GP to help you manage it. But there's nothing stopping you to come in to see a podiatrist to have a foot check. A yearly foot check, you should be having that, and that doesn't have to go through your GP. You can come and see a private podiatrist once a year, but knowing that you have someone to contact when you have a foot problem. So what I will say is, if you have a toothache, who do you go and see? The dentist. So if you have a foot problem, go and see a podiatrist. If you have a foot problem and you go to the GP, you have to, first of all, make an appointment. Who knows how hard that is at the moment? You then have to go and see them. So let's just say 3 weeks have gone now, and you've got a foot problem and you're diabetic. You then have to wait for them to see your foot and send a referral to your NHS podiatry. Let's say that's another week before it gets triaged. And that's just a clinician looking at the referral and saying, diabetic needs to be seen. You then get an appointment. Now we're looking at 6 weeks plus, and you still haven't had anyone look at your foot properly. Who knows about their foot? You then have to get an appointment with a podiatry. Now, if they're busy, the trust I work for, we will see any diabetic referral within 4 weeks, an ulcer within 24 hours to 48 hours, making sure that they can actually get to our clinic. We'll offer them the earliest appointment, and we will move appointments for anyone who has a wound on their foot, because the quicker you treat, the quicker we save. You then see the podiatrist and you then get treatment. So we're now looking, let's just say 2 months, potentially, that you haven't seen anyone. You can just go to your yellow pages or go to the HCPC website and go under podiatry or chiropodist, type in podiatry in your local area. If you're in my area in northwest London, I will come up, and you can find a HCPC registered podiatrist and go and see them. That means they are qualified, they have the insurance, and they are a healthcare professional. If anyone doesn't have, you wouldn't go and see a doctor without a GMC number, would you? So why would you go and see a podiatrist who doesn't have isn't HCPC registered under our governing body? Okay, so always see someone with the qualifications, because there are foot health practitioners out there who are not podiatrists. They do not have a degree in podiatric medicine like we do. They obviously may not have the experience that we have. I'm 13 years qualified. I have all of that knowledge under my belt.
And I think that's
So,
very sensible advice for anybody, really. If you're going to seek medical help, you need to go and check that these people have qualifications, and don't assume. Although, having said that, with our GP surgeries, we don't go and check their GMC numbers because we have assumed.
We assume,
But
I think with podiatry, it is a lot more vague. Just being honest, being in the industry, yes, there are people out there practicing at the moment who aren't podiatrists,
and I think
who aren't registered.
I think that's the same with a lot of those kind of professions where they're not a direct GP that you have to be aware of. So very, very quickly, last question: how do you get an annual foot checkup? Is that by default you would get one once you've been diagnosed with diabetes, or how does that work?
Okay, so an annual diabetic foot check should every single patient with diabetes should have an annual foot check with their GP or practice nurse, their diabetes practice nurse. I know that in Northwest London, where I work, this is happening. Okay. I don't know in other areas, but this should be happening. Every person with diabetes should have a diabetic foot check or an annual diabetes check. And within that annual diabetes check should be a foot check. That should be the pulses on your foot palpated with the hand and the monofilament. So the areas on your foot should be checked to see if there is any sensation loss. If whoever does that check, and I'm talking nurse or GP, if any of those are reduced, they should be referring you to your podiatry team to have just a bit more in-depth check, and they will then decide whether they need to review you every 6 months or whether you're okay. However, you can also see a private podiatrist and they can do your annual diabetic foot check for you as well.
Right.
So you just have to find a podiatrist, find someone that you get on with as well, because we don't just look at your feet. We're looking after you. There is a person attached to your foot. So find someone you get on with who you can connect with and feel that you can go openly about a foot problem, because I'll be honest with you, people don't like to talk about their feet. And where my clinic is, because it's inside a dental practice, I find a lot more men feel comfortable to see me because it doesn't say foot clinic, so everyone knows they're walking out because they've got their foot checked. So find someone that you feel comfortable to get your feet out and show them to, because you should be open and honest about your feet, because we hide them, and we only look at them when they're painful.
But an interesting comment that you said, that people feel, well, I suppose it's almost like embarrassed or ashamed to go to a foot clinic. Who knew?
I know. Everyone comes to see me and goes, I'm so sorry about my feet. I hate my feet. And I just go, don't worry. You're fine. Let me look after you. It's fine.
Yeah. And they are fine.
I see people with toes falling off every day. This is nothing.
Right. Well,
nothing.
Really lovely to see you again, Yatna, and thank you so much.
Thank you for having me again.
I'm very sorry about the technical issues at the beginning, but hopefully we're all good. Thanks very much, Yatna. Cheers, then.
Thank you so much.
Bye.